going to blank everything out. As soon as I do this, it's going to remove my webcam. So I'm going to add that in as well and show you how to do that also. So for this, I'm just going to call this TB demo. And as you can see, it took away my webcam, so I'm going to go ahead and add that by adding a capture device. And I'm just going to call that webcam. And that will get us taken care of there. Now, as you can see, when it first came on, it's really zoomed in and blown up. And on yours, if you see it and it comes in like this, all you have to do to fix that is you just change the resolution down.
Volume load of ear surgeries, they would have a different incidence. But overall, it's said to be around 3 per 100,000 in children, 9.2 per 100,000 in males, and the male-female ratio is roughly similar, is about males, slight male preponderance with about 1.4 to 1 ratio. What are the clinical features? Well, otorrhea in cholesteatoma is often scanty and is foul smelling. In the earlier days, in our undergraduate days, actually, we used to take a swab stick and actually take the smell to know what a cholesteatoma would smell like, because at that point of time, we did not have so much of imaging techniques, etc. And clinical acumen was actually the most important thing. Hearing loss could be conductive, it could be sensory neural, or it could have a mixed hearing loss also. The patient could present with tinnitus. There could be pain, which actually is an indicator of something serious about to happen. We could have a patient with vertigo. There could be facial weakness, or there could be diplopia if you have a lateral rectus palsy because of a petrous apex cholesteatoma. So this is a autoendoscopic examination of the ear, which shows you extensive cholesteatoma. So when we examine the ear, we could see a pars facida perforation, sometimes a clot or a scab in the attic in a patient who has history of ear discharge off and on. Actually should alert us, and we should take out that small clot. At best tell us there is a soft tissue mass, and it can tell us about bone erosions. It can tell us to a certain extent about ossicular status as well, but it cannot tell you whether it's granulation, whether it's cholesteatoma for sure. A CBCT has got the advantage of low ionizing radiation. There are many people who advocate actually a CBCT for imaging the ear. When we want to do a repeat imaging, maybe in a patient who has done a CT scan earlier, if you want to do it just before the surgery. MRI is a useful tool in our hands. The DW-weighted MRI is very useful, but the non-EPI DW-weighted MRI is even more useful, especially when we want to assess a post-surgical patient, because it has got less false positive findings. Non-EPI DWI, that is non-ecoplanar DW weighted imaging, provides less image distortion and has less artifacts. So when we do a CT scan, we could have soft tissue in the Prusak space. You can see the tympanic membrane here, or you could have something which is occupying the whole of the midlear cavity, but we can still see the ossicle sitting there. We could have an erosion of the lateral semicircular canal in a disease which is occupying the mastoid antrum as well as the midlear cavity. And but it cannot tell us for sure whether it is a cholesteatoma or granulation or something else. When we have a patient of cholesteatoma, we do not have any other treatment to offer other than surgery, because suction clearance used to be done at one point of time, but that is something which only delays the inevitable. So we need to go for surgery. So what are the goals of surgery? The goals of surgery are: number one, to eradicate cholesteatoma completely; number two, to give the patient a dry ear; and three, to improve or preserve hearing; and number four, cosmesis. Cosmesis is in the form of not having a gross deformity in the external canal by doing a very bad myotoplasty. And when we do a lot of drilling, we have a huge mastoid cavity. And if we are not sort of obliterating it, then you could have a depression in the posterior region in the long run. The choice of mastoidectomy could be a wall up or a wall down procedures. In this talk, we are not going to debate upon which is better or which is worse, because there's been a lot of debates on regarding wall up and wall down procedures. And the canal wall down procedures has got the disadvantage that we have a, as some doctors say, it's a doctor dependent cavity, because the cavity needs to be cleaned once in a while. But it has got the advantage that you can look inside the corners. The canal wall up procedure actually has the advantage that you do not have a cavity which needs to be cleaned. It's very useful when patient needs to wear a hearing aid. You don't have to protect the ear from water, but then you need to have a reloop, or you have to do repeat MRIs to actually assess whether there is any recurrence of the disease. Most of us nowadays try to do the ossicular reconstruction. In India, at least, we do it as a single stage most of the time. When we are doing a wall down procedure, we try to obliterate the cavity as much as possible. And of course, there will be other surgical procedures involved for complications. Complications in the sense when we have a sigmoid sinus thrombosis, maybe a thromboembolectomy may be necessary, which is not very common nowadays, but we could still have a gap in the dura where there might be some prolapse of brain matter, which may need a little bit of bipolar cauterization and a repair of that area. Or when we have a labyrinthine fistula, we may need to do some little bit of repair in that area as well. Let us look into certain things that always intrigue us. Cholesteatoma is actually worrisome because there is a lot of bone resorption and bone destruction. Why does it happen? It is thought to be due to inflammation. Local pressure is another factor which can cause bone resorption. There are specific cytokeratins which can be the reason of bone resorption in cholesteatoma. Granulation tissues which produce lysosomal enzymes, collagenase and prostaglandins can cause bone resorption. Excessive host reaction in the form of paracrine and autocrine secretions. Angiogenic growth factors like cyclooxygenase 2, interleukin-8, platelet-derived growth factors, epidermal growth factors, and vascular endothelial growth factors released by inflammatory cells in the matrix and the perimatrix actually can lead to bone resorption. Upregulation of cytokines such as interleukin 1, 6, and 17 and interferon beta actually promotes inflammatory bone resorption also. It has also been seen in the recent times that matrix metalloprotease 9, MMP9, can degrade type 4 collagen, receptor activator overexpression of nuclear factor K ligand, which is called RANKL in short, and low expression of osteoproteogerin, OPG, in cholesteatoma perimatrix could be responsible for bone resorption. Moreover, we have colonization of bacteria and formation of biofilms which aid in the persistence of inflammation. In fact, when we have a complication of cholesteatoma like a meningitis or maybe a brain abscess, then the cholesteatoma per se actually does not extend into the brain. The cholesteatoma actually leads to the erosion of the bone in the mastoid and the associated infection that is there with the cholesteatoma matrix would actually cause the other infective processes that come along with it. Histopathology is something which is a requirement nowadays. We need to send, especially for medical legal as well as for reimbursement issues. Nowadays, examination of histopathology is important, and we should actually send most of all the material that we take out for a histopathological examination. And what are the requirements for a diagnosis? A combination of squamous epithelium, granulation tissue, and keratinous debris is actually a requirement for diagnosing a sample as cholesteatoma. The essential diagnostic feature of the matrix consists of keratinizing cytologically bland stratified squamous epithelium that is arranged in convoluted cyst-like formation. The epithelium may range from thin to atrophic. It lacks ratty ridges and shows granular cell layer with abundant keratohyalin granules. Some cholesteatoma actually overexpress Ki67, a cell proliferation marker of tumors and non-neoplastic proliferative disorders. And CK17, which is a marker of keratinocyte differentiation, is a predictor of aggressiveness and invasive capabilities when it is present. So now, even for cholesteatoma, we have got certain markers. Now let us come to the subject proper. As I said, the first few slides would be just as an introduction to cholesteatoma. Now, this is what we have come here to discuss today. Classification. There have been attempts by various workers over time to sort of classify and stage cholesteatoma, because cholesteatoma has been an enigmatic subject for a long time. No wonder that this disease actually invites an international conference every couple of years, which is the International Conference on Cholesteatoma. And so it has been a problem which has been going on. We have not been able to know the disease process in toto, though we have been trying to figure out the management strategies. So TOS proposed an autoscopic classification based on the site of disease origin. He divided cholesteatoma into number 1, attic, number 2, pars tensa 1, which was the marginal disease, and pars tensa 2, central disease. Mills and Fadgam actually added a 4th category to the proposed TOS classification to include cholesteatoma behind an intact TM, the intact eardrum type. In 1964, the Committee of Conservation of Hearing of the American Academy of Ophthalmology and Otolaryngology published a standard classification to guide in surgical management. Type and location of cholesteatoma was described in gross description of the disease during surgery. Sana et al. Actually divided petrous apex cholesteatoma into 5 types: supralabyrinthine, infralabyrinthine, massive labyrinthine, infralabyrinthine apical, and apical. In 1984, Lien described a CAO classification, which was based on the extent of cholesteatoma, which is C, the degree of drum atelectasis, which is A, and the amount of ossicular erosion, which is O. So this was the CAO classification of Lien. In 1989, TOS and Lau proposed a classification system which became very popular. This system includes 3 categories. Number 1, attic cholesteatoma, which develops from pars facida and fills the Prusak space. Number 2, pars tensa retraction cholesteatoma, which develops from retraction or adhesion of entire pars tensa and involves the tympanic orifice of the eustachian tube. And number 3, sinus cholesteatoma, which develops from a posterior superior retraction or perforation of the pars tensa and extends to the sinus tympani, posterior tympanum, and beyond. TOS claimed that this system was useful for selecting the surgical procedure as well as for determining patient's prognosis. In 1999, Saleh and Mills proposed a classification based on the site of cholesteatoma. It was called the SOC classification: S for cholesteatoma, O for ossicular damage, and C for preoperative complications. They claim that this system reflects the severity of the disease. Preoperative complications means when the patient presents before surgery, whatever complications existed. In 2008, the Japan Otological Society, JOS, proposed a classification system for attic cholesteatoma based on the extent of disease and the associated complications. In 2009, Telmesani et al. Proposed a ATM class system for classification of cholesteatoma, which includes A, attic, T, tympanum, and M, mastoid, based on the extent of disease, whether the disease was in the attic and tympanum, or attic only, or it may whether it has involved a mastoid. 2012, Bilal et al. Presented the TMC classification, which was based on the site of pathology in the tympanic cavity, T, its spread to the mastoid, M, and the presence of complications, C. A high correlation was observed in both the ATM and TMC classifications in terms of otoscopic and CT findings with intraoperative surgical findings. Now, in 2017, actually, the IANO and JOS classification was proposed. It was based primarily on the extension and complications, and it aims to standardize the reporting of surgical techniques. This was actually presented as a consensus paper in the International Conference on Cholesteatoma in Edinburgh, probably in 2016. So the IANO-JOS Joint Consensus Statement on Definitions and Classification and Staging, which were in this, since it was a consensus statement, it did not have 100% agreement on every single point by all the people who were involved. It goes on to say in this paper that has been shown here that around 89% approval on the statement regarding the definitions of cholesteatoma, and around 98% on the classification of cholesteatoma, and so on and so forth. So what does the IANO and JOS classification say? Well, the IANO and JOS classification actually divides cholesteatoma into congenital, acquired, and unclassifiable. The acquired can be a retraction pocket cholesteatoma, which could be a pars densa cholesteatoma, a pars flaccida cholesteatoma, or a combination of a pars flaccida and a pars densa. Whereas the acquired non-retraction pocket cholesteatoma could be secondary to a TM perforation, or could be following trauma or iatrogenic causes. And post-surgery cholesteatoma, which is a different entity, which could be a recurrence or a residual. As I mentioned earlier as well, there is always that little bit of confusion whether it's a recurrent or a residual cholesteatoma. And this classification also divided the middle space into the stamp system in order to simplify the extent of the cholesteatoma. The middle ear and mastoid space are divided into 4 sites. The difficult access sites S, tympanic cavity T, attic A, mastoid M. The difficult access sites are the S1, which is the supratubal recess. This is the eustachian tube, the supratubal recess area, also called the anterior epitympanum or protympanum. And S2 is the sinus tympani. These are defined as the difficult access area because this is where cholesteatoma usually is left behind. The posterior border of the attic was defined as the posterior end of the incus short process or the fossa incutis. So this is where the attic ends and the mastoid antrum begins. And the mastoid includes the antrum and the mastoid air cells, this whole thing. The IANO-JOS staging classification system also applies to 4 types of middle ear cholesteatoma. The staging is as such. Stage 1, cholesteatoma localized in the primary site, whether it is pars flaccida or pars densa, it's localized in one particular site. Stage 2 is cholesteatoma involving 2 or more sites. Stage 3 is cholesteatoma with extracranial complications or pathological conditions, which may include facial palsy, labyrinthine fistula, postauricular abscess or fistula zygomatic abscess, etc. And canal wall destruction also is included as an extracranial complication. And stage 4 will be cholesteatoma with intracranial complications like meningitis, epidural or subdural abscess, sinus thrombosis, brain herniation, but it does not apply to petrous apex cholesteatoma. So the staging systems for the representative we have already mentioned in general. So if it's a pars flaccida cholesteatoma or an attic cholesteatoma, stage 1 when the cholesteatoma is localized in the attic, stage 2 when the cholesteatoma involves 2 or more sites, 3 when the cholesteatoma is with associated with some extracranial complications, and 4 if there is associated intracranial complications. And similar is the case with pars densa cholesteatoma as well. Well, this is a very busy sort of slide. I will just take you briefly through the different definitions that have been shown here in this Yano and Joss classification. They have given different definitions and statements on cholesteatoma. Number one, they have said that cholesteatoma is a mass formed by the keratinizing squamous epithelium in the tympanic cavity and or mastoid and subepithelial connective tissue, and by the progressive accumulation of keratin debris with or without a surrounding inflammatory reaction. Number two, they have said cholesteatoma consists of matrix, which is keratinizing squamous epithelium, perimatrix, varying thickness of the subepithelial connective tissue, and keratin debris. Number three, they have said the pathophysiology of cholesteatoma is not completely understood. Number four, recurrent infections and inflammatory reactions in the subepithelial connective tissue of cholesteatoma contribute to bone resorption in the adjacent areas. Number five, cholesteatoma is diagnosed with a detailed otoscopic history, physical examination by automicroscopy and endoscopy with or without imaging. Sixth, they have said that cholesteatoma is classified into two general categories, congenital and acquired. And seven, they have actually defined what is an acquired cholesteatoma. And then they have said the retraction can develop into an acquired cholesteatoma when it loses its ability for self-clearing. They have also said about acquired cholesteatoma is not present in birth, and it may develop from a retraction pocket in the pars flaccida. And they have gone along to say that ultimately that the different classifications of the cholesteatoma that we have already discussed. Okay. Now let's move on to the Cole classification or the Cole classification. This classification actually was developed by a group of Swiss otologists, and they also did a multicentric sort of trial on this classification for a lot of years. And incidentally, this classification was also presented in 2016 International Cholesteatoma Conference in Edinburgh at the same time as the Iano-Joss consensus classification was put forward. But there are certain basic differences between these two classifications. And you can see here that one of the participants in this whole classification has been one from or nearby Nepal, Dr. Shankar Shah. So that's a good thing. So what does this classification do? This classification tries to define the extension of cholesteatoma and stage it. They also comment on the status of the ossicular chain at the end of the surgery. They talk about the complications and the degree of pneumatization and ventilation. So that makes this CH, O, L, and E. Plus, they give a numeric value rule to stage this cholesteatoma from 1 to 3. The basic difference, we will come to that between the Iano-Joss and the Cole classification is that the Iano-Joss classification does not talk about ossicular chain, and it does not talk about pneumatization and ventilation. So, and there are certain other basic differences that we will talk about again. The final goal in the Cole classification is to evaluate and compare different surgical approaches and philosophies, and not necessarily to evaluate the pathogenesis of COM with cholesteatoma formation. So they were more interested in knowing about which surgical approach would be best. The whole aim of this classification, the system of classification, was to find out which surgical approach would actually work out better, what approach strategy would work out better for different types of cholesteatoma. So with that in mind, the whole cholesteatoma staging was made, The cholesteatoma was staged according to extension. When CH value of X is when there's no disease, no identifiable disease. 0 is again no disease. 1, we have got staging from, we'll come to that again in details. 1, 2, 3. 1 and 2 have been divided into 1A, 1B, 2A and 2B. Similarly, ossicular chain status has been shown as no ossicular destruction as O. 1 could be 2 types, 2 could be again 2 types, and this is 3. Life-threatening complications, which is shown as L, it could be none, which is 0, or if you have it, score is 2. And station tube ventilation or mastoid pneumatization. This could, if more than 50% of the cells are aerated, it is said to be good ventilation when the score will be E0. And if there is moderate to good pneumatization, with poor ventilation, that means less than 50% of the cells are aerated, then the score will be 1. And if you have a sclerotic mastoid with poor pneumatization, then and ventilation, it would be a score of 2. And this actually, according to the proponents of this classification, is that it could be assessed on the basis of a CT scan by looking at the pneumatization of the mastoid, or it could be an intraoperative assessment. Similarly, ossicular chain status is not at the beginning of surgery. It is at the end of surgery. So, as I said, a score of 1 regarding the disease extension when the disease is confined to the middle space, including the Prozac space. There is no involvement of 1A is when there is no involvement of the sinus tympani. B, when there is involvement of the sinus tympani. They have not given as much importance to protympanum in the initial stages, because the argument is that since protympanum is not such a difficult area compared to sinus tympani. But in the grade 2, where they have said that 2A is when the disease involves the middle ear, the attic, and it has just extended to the antrum, going up to the level of the lateral semicircular canal. Not involving whole of the mastoid antrum, just going to the level of the lateral semicircular canal. 2B, when the disease is also gone into the protympanum as well as the sinus tympani, along with the 2A extension. And destructive, when it is beyond these descriptions, it has gone beyond that. If you have a 4A, when you have a supralabyrinthine or infralabyrinthine extension, and if it's a petrous apex cholesteatoma, then it's a 4B grading. For ossicular destruction, a score of 0 when you have an intact ossicular chain, score of 1 when malleus and stapes are present, but the incus is eroded or missing, and 2 when the malleus is present, the incus is absent, and only the stapes superstructure is also absent, only the foot plate is present. And these actually are similar to the Austin Cartouche class A and the FIC 1 classification of ossicular status. Then 3 would be when the stapes. 3A is when you have only the stapes, no incus, no malleus, and we have only a mobile footplate, that would be 3B, where the superstructure is not there. 4A is a situation where we have only a fixed footplate. 4, not 4A or B, it's just 4 when you have a fixed footplate, stapes footplate only. As I said, there are certain basic differences in the Yano, Joss and the Cole classification. This also extends to the comparison of the intracranial and extracranial complications. The Yano and Joss classification, if there is an extracranial complication, immediately it is a stage 3 disease, stage 3 cholesteatoma. Extracranial complications could be facial palsy, labyrinthine fistula, labyrinthitis, postauricular abscess or fistula, zygomatic abscess or neck abscess. And if there is an intracranial complication, it would immediately be a stage 4 disease. like when you have a pleural meningitis, epidural abscess, subdural abscess, brain abscess, sinus thrombosis, or brain herniation into the mastoid cavity. The Cone classification, actually, when there are extracranial complications, it assigns 2 points. It does not immediately make it a stage 3 or a stage 4. It is assigned 2 points. And the extracranial complications that have been enumerated are facial palsy, labyrinthine fistula, but not a pre-fistula, labyrinthitis, mastoiditis or mastoid fistula, Bissol's or Lux sepsis, tegment defect requiring surgical repair. And intracranial complications are given 4 points, which includes meningitis, brain abscess or extradural abscess, seizures, sigmoid sinus thrombosis. But simple brain herniation, because of a defect in the tegment, does not make it a intracranial complication, because according to the the proponents of the whole classification, they say that the little brain herniation, as I mentioned, can be bipolarized and the defect in the tegment can be repaired, which does not need a huge surgical skill. Similarly, regarding the staging system of both the things, in Iono-Joss, you have the staging system for the respective cholesteatoma, as I mentioned, localized to one side, 2 sides, extracranial and intracranial, and that would make it 1, 2, 3, and 4. But in the Cone classification, you sum up the C values, the O values, the L values, and the E values. If the sum is between 1 to 3, it is stage 1. If the sum of the classification is between 4 to 8, it would be a stage 3. And if the value is more than 8, only then it would be a stage 3. So in the stage 2, you could have an extracranial complication, but still if it is below 8, it would stay, and be between 4 and 8, it would still remain in the stage 2 disease. Whereas in Iono-Joss classification, it would immediately go into a stage 3 disease. Let us look at some case sort of scenarios. So this is a patient which we have labeled as CH2A, O0, L0, and E0. That means that there is no ossicular destruction, no extracranial or intracranial complications, and the pneumatization is good, more than 50% pneumatization. And so this is a patient where we had a good intact ossicular chain. We had opened the mastoid antrum also. The cholesteatoma had just about gone into the antrum. So that is why it's a 2A sort of classification. It's to the level of the external ventricle. As you can see here again, the ossicles, this is the stapes, the long process of the incus. The attic region has been drilled out. There's a little bit of cholesteatoma which is left to be removed. And this is the handle of malleus. The chorda is intact. So this is a situation where the ossicular chain is intact. There was cholesteatoma which was taken out, and this makes it a early disease, a stage 1 disease, because it is between less than 3, that is 1 to 3 score. It makes it a stage 1 disease. So there's another patient where we had a 2A cholesteatoma with a 3A ossicular destruction, and 3A means we have the stapes superstructure. The incus and malleus are both absent, but there is no extracranial complication, and there is no, the pneumatization is also good. So here you can see the cholesteatoma being dissected off, the matrix being dissected off in the antrum. This is the cholesteatoma matrix. And you can probably make out the foot plate here, the stapes superstructure, which has been gradually denuded. And the other ossicles are all missing. But there is extensive disease going into the mastoid antrum completely. So we have given it the going up to the level of the lateral semicircular, that makes it a 2A sort of thing. Then we have a 2B ossicular chain intact, no extracranial and good pneumatization. This is another case where we have this situation. You can see this, the disease is more in the protympanum or epitympanum, in the supratubal area. The chorda is intact and the ossicles were also intact in this patient. We can have extensive disease with CH3O1 and 0E0. This is another patient where you can see it looks like it's just a retraction pocket, but when we went in, there was quite a lot of disease and it was a wall down procedure. And this is what the attic looked like. Then I take you to this case where we had extensive cholesteatoma, ossicular destruction was there, and the pneumatization was also a little less. We had said it's E2. So again, this is the picture of the disease where it has been partly drilled out. Now you can see in the whole classification, even if the facial is exposed, it does not change your staging. An exposed facial actually does not alter your surgical plan, or a labyrinthine fistula does not, where the labyrinth is just eroded and the membranous labyrinth is not, ruptured or anything. It does not alter your plan. That is why they have said the exposed facial nerve, which is not a very uncommon situation, does not change your plan of surgery. Then we have this last case where we have an extensive disease which is 4A, which means it has got a extracranial, extramastoid spread, and then we have destruction of the ossicles. Cholesteatoma 4A means we have got a infralabyrinthine spread, we have got a ossicular destruction, then we have got a extracranial complication, and there's diploid sort of, it's less than 50% pneumatization of the mastoid. So you can see the handle of malleus there. You can see there is extensive cholesteatoma which has been dissected off gradually from the mastoid and hair cells. And here you can see that this is the infralabyrinthine extension. It's going down. This is the mastoid tip area. The bone is dehiscent here. And this was actually not a visual sepsis, but it was the bone in the mastoid tip was already eroded and it was about to evolve into a visual sepsis sort of situation. So that is why we have said this is a L1. And this is how we can actually sort of standardize our reporting, because over the years what has happened is we often see many people doing a lot of cholesteatoma surgeries, but when they report, write down their notes, their surgical notes would maybe say a large cholesteatoma removed, or maybe just diagnosis of CSOM unsafe, CSOM EAD, or it could be squamous cell disease. Then the surgical description would be just a huge cholesteatoma or a large cholesteatoma removed, ossicles eroded, no incus, no malleus. Yes, that description also says that, but there's no standardization. So maybe if we all look at it in a serious way, we could have better categorization of the disease that could help us in understanding better, because cholesteatoma is something which is not a one-off situation. We need to follow up the cholesteatoma patients, which we have learned over years, lifelong. These patients need to be told in the very beginning that you have to be on follow-up, because there is a chance of a recurrence, even though it may not be there in all patients. So better reporting and standardization, because when people move from one place to another, if I do a surgery in Guwahati and that patient goes off to Bangalore or Mumbai, somebody in Mumbai and Bangalore should be able to make out from my notes about what was the operative status at that point of time. So, and looking at the patient's outcomes, we can all, compare our surgical outcomes over the years. Thank you very much. I said I'll finish by around 45 minutes, so I think I have done that. I'll stop my share and see if any. Thank you very much for.
Sir, I have posted